Welcome to Understanding the Radiographer's Role in Radiation Safety and Image Quality. This module was created by Nina Kowalczyk, Stephanie Johnston, and Bruce Long. At the conclusion of this module, you should be able to explain the current best practices in fetal and gonadal shielding to colleagues and patients, optimize radiation dose to patients following current evidence-based safety practices, advocate for compassionate care and safety while utilizing image optimization practices to obtain high-quality radiographic images, and define the acronym IMAGES and how it applies to the practice of radiography. The previous modules have provided an historical timeline and discussion of tissue weighting factors and concerns regarding radiation exposure to the fetus and gonads. In addition, the previous modules have also presented information regarding shielding practices and other technologic improvements in imaging receptors and radiologic imaging equipment which have been implemented over the past 30 years to reduce patient dose while optimizing image quality. Current research suggests the discontinuation of fetal and gonadal shielding, which is a dramatic shift in the practice of radiography, and many professionals may find it hard to implement. It is important to stress that this change in shielding only applies to abdominal shielding of the reproductive organs and the fetus during abdominal and pelvic imaging. Shielding of the thyroid gland during dental radiography and mammography, shielding of the breast tissue during scoliosis radiography, and shielding of the lenses of the eye are still appropriate clinical practices. This module is focused on helping us all move to a new paradigm based on current evidence-based science regarding the discontinuation of fetal and gonadal shielding. Since April of 2019, there has been considerable discussion about the use of patient gonadal and fetal shielding in diagnostic X-ray imaging, prompted primarily by the publication of a position statement on this topic by the American Association of Physicists in Medicine, otherwise known as AAPM. This statement is based on a consensus among medical physicists that the routine use of patient gonadal and fetal shielding, once a mainstay of patient radiation protection, may no longer be best practice for protecting our patients. The AAPM statement was intended to be the beginning of a much larger conversation, one that includes many other stakeholders, organizations, and individuals. Its purpose is to educate the imaging community that these fetal and gonadal shields provide no tangible benefit to patients, may compromise radiologic examinations by interfering with important patient anatomy, or may actually increase patient dose to more sensitive organs such as the stomach and colon when placed in the X-ray beam path and detected by an automatic exposure control system. While science can lay the groundwork, facilitating a data-driven discussion, any meaningful dialogue about potential changes to clinical practice must include all members of the medical imaging community. Radiologic technologists, medical physicists, health physicists, radiologists, and regulatory agencies are all committed to the same goal: the safe and effective use of medical imaging. Each member of the imaging community brings a unique and valuable perspective to the discussion, all of which must be considered as potential changes to clinical practices are contemplated. We all are on the same team working towards ensuring excellent patient care and safety. We are all in agreement about the as low as reasonably achievable, or ALARA principle, and this change in clinical practice does not undermine the fact that we are all responsible for ensuring our patients receive the lowest possible radiation dose in combination with the creation of an optimal diagnostic image. Radiographers must employ excellent communication and listening skills with each patient. In instances when the patient is unable to communicate, it may be necessary to converse with a family member or caregiver. Explain the procedure to the patient prior to beginning the procedure and let them know what to expect during the procedure. Tell them you will need to touch them to properly position the anatomy. Inform the patient regarding current shielding practices, why the patient does not need a shield, while perhaps a parent, family member, physician, or radiographer may need to wear a lead apron. Carefully listen to the patient or family member's concerns and provide factual responses. As radiographers, we are specifically responsible for ensuring the proper patient procedure by checking the requisition or consult to verify the examination is appropriate in reference to the clinical information provided, verifying with the patient that the examination correlates with symptoms such as the correct body part, and to ensure the images obtained are consistent with department protocol or the ordering physician's preference. Radiographers must ensure proper patient positioning, including the correct orientation of anatomy to the exposure field for each radiographic projection, the correct size of the exposure field, the correct orientation of anatomy to the central ray, assessing correct entrance and exit points, rotation, central ray angle, and the correct placement of the right or left marker. We must also ensure proper collimation with the exposure field is limited only to the required anatomy. This will minimize radiation exposure and limit scatter radiation to the image receptor, optimizing image quality. As radiographers, we are responsible for selecting optimum exposure factors using technique charts and consulting exposure index values to ensure use of optimum KVP and MAS. This requires the use of up-to-date technique charts and anatomic programming to ensure the use of optimum KVP and MAS. The KVP should be based on the specific body part and digital imaging system, for instance, computed or direct radiography. Use of KVP that is too low will result in reduced image quality, and use of KVP that is too high results in excess radiation exposure to the patient. Appropriate MAS can only be evaluated by correlation with deviation or exposure indices following image processing. Radiographers must ensure no artifacts are within the image. This includes requesting patients to remove any clothing or other items within the exposure field that might create an artifact on the image. In instances when the patient is unable to communicate or comply with instructions, the radiographer must check for potential artifacts and remove them before making the radiographic exposure. It is also extremely important to utilize proper image processing protocols. Correct algorithms must be used when processing the digital images, and post-processing collimation should never be used in place of collimating to the anatomy of interest while positioning the patient. As mentioned in the previous slide, appropriate MAS can only be evaluated by correlation with deviation or exposure indices following image processing. Use of MAS that is too low will result in reduced image quality. Use of MAS that is unnecessarily high will result in excess radiation exposure to the patient. It is very important for radiographers to be constantly monitoring for dose creep. As educators, it is paramount that we ensure graduates are competent to correctly operate imaging equipment following ALARA principles discussed earlier, including proper positioning, collimation, optimized exposure, and digital processing. We must also educate radiographers that technological advancements in modern imaging equipment, such as automatic exposure control, automatic brightness gain, and automatic dose control, have created an environment in which introducing a highly attenuating gonadal shield into the imaging field, meant to protect the patient, results in an increase in patient dose because the tube output increases in an attempt to penetrate the gonadal shield. Helping students understand the most current tissue weighting factors will also allow them to discern that the use of the gonadal shielding during pelvic and abdominal radiography actually results in higher exposure to much more sensitive organs such as the intestines and the stomach. Lastly, we must ensure graduates understand digital imaging equipment and concepts such as deviation or exposure indices and dose creep in an effort to ensure optimizing patient dose. As professionals, we must also keep abreast of the evidence presented in the most current peer-reviewed literature regarding radiation exposure risks and advancements in radiologic equipment so that we can promote best practices and educate our patients, their families, and our colleagues. It is our responsibility to understand best practices in terms of shielding so that we can provide excellent and safe patient care. Remember, current research suggests the discontinuation of fetal and gonadal shielding only, not the shielding of the thyroid, breasts, or lens of the eye. So how do we facilitate a meaningful, evidence-based dialogue with our colleagues, students, and the public? How can medical imaging and radiologic science educators and radiology administrators use this information in clinical practice and in the development of policy and procedure guidelines? This is the purpose of creating the AAPM Communicating Advances in Radiation Education for Shielding, or CARES Committee. Recognizing that removing patient shielding from routine use is a substantial shift in existing clinical practice, CARES was formed to bring together stakeholders to discuss potential changes in the use of patient shielding. The committee includes representatives from many different societies and organizations with specialization in medical imaging and patient safety. In most situations, it is appropriate for the radiographer to explain why shielding is not recommended, but shields may be used at the discretion of the radiographer, provided that careful attention is given to ensuring that image quality is not compromised and overall dose is not increased. It is important to recognize that there will be situations that require professional judgment based on the individual patient and circumstances. Ensure that you are educated and fluent with best practices to provide accurate information to the patient, their families, and our colleagues. Use time when you are introducing yourself to the patient to explain the procedure and current best practices. AAPM CARES Committee have resources available such as frequently asked questions with 3 different sections, each with a different target audience: the health professionals, the adult patients, and parents or other caregivers of pediatric patients. As always, it is every radiographer's responsibility to follow best practices, advocate for patient and workplace safety, maintain a clean and safe workspace, and promote a healthy work environment. In addition to frequently asked questions, AAPM CARES also has resources available to help radiology management work with health physicists in updating radiation safety policies. These documents were developed by AAPM's Committee on Education and Implementation efforts for discontinuation of use of patient gonadal and fetal shielding, with input from the following contributors: the American Association of Physicists in Medicine, the American College of Radiology, the American Society of Radiologic Technologists, the Association of Educators in Imaging and Radiologic Sciences, the Canadian Organization of Medical Physicists, the Conference of Radiation Control Program Directors, Health Physics Society, Image Gently, Image Wisely, and Radiological Society of North America. Images. Since we create images as radiographers, it seemed reasonable to choose this acronym using the word images to assist radiographers in remembering the key concepts related to providing quality care to patients while optimizing image quality. The letters in images acronym stand for inform, manage, advocate, give, educate, safety. These 6 concepts are part of every encounter with every patient during the imaging process. One or more of these concepts may be emphasized depending on the situation, but each is just as important as the other. Each concept relates to the patient and the radiographer, and all come together as we perform at our best for our patients. Just as we need all of these letters to complete the word images, we need all of these concepts to provide quality care while we acquire the best images. Let's discuss each of these in detail and look at each from both perspectives. I is for inform. First, you must be informed about the best practices in radiation safety. What is the best way you can perform the required imaging and keep the patient the safest? Inform the patient about the radiologic procedure and best practice in radiation safety. Utilize resources and information in these modules to help inform patients, family members, and caregivers, as well as other health professionals. M is for manage. Manage radiation exposure to the patient and others by using appropriate exposure factors and remaining diligent to procedural best practices. Manage radiation exposure to the patient by selecting optimum exposure factors, using technique charts, consulting EI values to ensure optimum KVP and MAS, perform the appropriate procedure, perform proper positioning, perform proper collimation, ensure image artifacts are not created, and only use patient shielding in exceptional circumstances. In most situations, it is appropriate for the radiographer to explain why shielding is not recommended. However, if the patient or caregiver continues to insist that shielding be used, shields may be used at the discretion of the radiographer. While we propose some general rules for discontinuation of the use of gonadal or fetal shielding during pelvic and abdominal imaging, it is important to recognize that there will still be situations that require professional judgment based on individual patient circumstances. A is for advocate. Advocate for the patient and the profession by practicing and sharing what you know about radiation safety best practices. We cannot overemphasize communicate, communicate, communicate. G is for give. Commit to give the highest quality care to all patients and quality imaging examinations to the radiologists and referring physicians. Let the patients know you are a professional and care about the quality and accuracy of the radiologic procedures. E is for educate. Educate yourself, your patients, and the public about radiation safety best practices. Be a lifelong learner and continue to stay current in your profession. Be prepared to answer questions referencing evidence-based science and current federal, state, and institutional radiation safety recommendations. S is for safety. Safety should be a top priority in your delivery of care, as well as creating a healthy and positive work environment. Clinical practice should be based on the best and most recent scientific evidence. Although patients expect to be shielded because it has been common practice for many decades, we should explain to the patient the benefits from shielding are negligible, and thus there is no value to continuing this practice. Further, there is a small risk of compromising the examination if the shield enters the exposure field. There are situations, however, that may require special consideration. For example, if a pregnant patient with suspected pulmonary embolism refuses to have imaging done without shielding, then the benefit of getting a timely diagnosis outweighs the risk posed by using shielding. Similarly, for the parent of a critically ill pediatric patient, the psychological benefit to anxious parents or caregivers may exceed the risk posed by shielding. In most situations, it is appropriate for the radiographer and/or the physician to explain why shielding is not recommended. If the patient or parent continues to insist that shielding be used, shields may be used at the discretion of the radiographer, provided that careful attention is given to ensuring that image quality is not compromised and overall dose is not increased. While we propose some general rules for discontinuing the use of gonadal or fetal shielding during pelvic and abdominal radiography, it is important to recognize that there will be situations that require professional judgment based on the individual patient and circumstances. So, in summary, I stands for inform. Inform both the patient and yourself about radiation safety best practices. M stands for manage. Manage radiation exposure to the patient and others by using appropriate exposure factors and remaining diligent to procedural best practices. A stands for advocate. Advocate for the patient and the profession by practicing and sharing what you know about radiation safety best practices. G stands for give. Give the highest quality care to all patients and quality imaging examinations to the radiologist or referring physician. E stands for educate. Educate yourself, your patients, and the public about radiation safety best practices. S stands for safety. Ensure safety is at the forefront of your delivery of care to create a healthy and positive work environment. Change is essential. We can do this together by following updated radiation safety and image quality best practices regarding the discontinuation of fetal and gonadal shielding and using the images model. The AAPM Committee on Communicating Advances in Radiation Education for Shielding, or CARES, is committed to sharing the newest evidence-based recommendations with radiology community. For more information, please visit the website cares@aapm.org. Thank you for participating in this module.